BioBalance Healthcast, Episode 125, Rationing in the American Healthcare System.
BioBalance Healthcast features conversations about positive aging. Your hosts are Dr. Kathy Maupin, Medical Director of BioBalance Health and a leading expert in treating symptoms of aging, and Brett Newcomb, a licensed professional counselor.
One of the most important objectives that we have in doing these podcasts is in support of our commitment to helping you be an informed consumer. We think that being a participant in medical decision making from the standpoint of being an informed consumer is a critical goal that all of us should have who deal with American medical systems and who personally have to make decisions about our own health care. So a topic of conversation that is of increasing importance relative to good medical decision making is the question, the global or generic question about rationing. When you talk about an aging population that is going to increase the level of consumption needs for critical care as they age, then decisions have to be made about the economics of that and the medicine of that. And so a conversation needs to be had about the concept of rationing, and whether that's good medicine or good economics or good decision making or whatever it is, wherever you stand on that topic. So today I thought that I would ask Kathy some questions from a physician's perspective who has 30 years of experience in the existing medical system, who has seen it evolve in the way that practices are run and hospitals are run and insurance companies are run, and who is looking at the data she's getting about where prospective changes may go. I may have layman's reactions to things about this, but they're not as informed as they need to be. So partly I'm asking these questions today to help me become more informed. So rationing is not a word that people like to use because it scares everybody.
But there's no option. We have to talk about it because the government's talking about it.
Yes.
They talk about how to take the money that's in the system and ration it so that everybody gets enough health care. Okay, right now we're
the lowest common denominator.
Right.
How do we keep the biggest number of people in the zone?
With the lowest amount of health care, basically, because there's a certain amount of money, there's a certain number of people, and we're talking
a
about
number of drugs. I mean, when you have shortages of equipment or supplies.
And we will. When you stop paying good high prices or decent prices for things, people stop making them. People who are in the business of making drugs, if it doesn't make money, they stop making it, even if it helps a small number of people. But what I'm talking about today, Journal of the AMA and New York Times had articles in the last month on rationing, and they said, you may not want to look at it, but you have to. And every American has to look at it because that's what Obamacare is.
Okay.
It's rationing health care. But they are looking at it like the doctor is rationing what we have for the patient in front of them. Now, we're not taught that. Our Hippocratic oath is to take care of the person in front of us, that one patient, and to take care of them to the best ability that we have, which may mean money, which may mean cost, and to the best health that they can have. So it means we have to look at what the problem is right now for one patient, and what we do today is going to cause them to feel or be able to work or be able to stay out of the healthcare system. What can we do today that makes them better? What can we do today that's going to make them better for the longest period of time? That's what we're taught. That's what we're supposed to be doing. And really, governments look at, from the top down, a group of people, a group of money. You can have this, you can have this, you can have this, you can't have anything else. So our perspective as physicians is so different and should be so different. It's like, that's why we have government, that's kind of history and government's your field. That's why we have different centers of power and we balance power. Well, doctors are the only thing holding you back from having no medicine at all, because the cheapest medicine is to let you die, and the second cheapest is to give you something that makes you better right now and get you out of the doctor's office. You may come back 5 times, but right now, that's the cheapest medicine.
Well, at least it's arguable that that's the cheapest medicine, but that's not necessarily what you find when you look at it.
It's not the cheapest medicine in the long run.
No, there were some articles recently in the St. Louis news media about hospitals cutting down on return visits of elderly patients by doing follow-up aftercare.
Oh yeah, well that's true.
And you get them in, their knee hurts, you give them something for their knee, you send them home. They don't get adequate information or follow-up supervision for how to change their bandages or how to take their medicines. Some of them are confused, their hearing, their vision, their balance, whatever. If you've ever treated somebody that's elderly or tried to deal with them, they may have 75 medicines that they have to take every 3 hours. You know, you got layers of weak boxes with pills in them for 2 a.m. and 7 a.m. and all that stuff gets confused.
That means you have to have a caretaker. And a caretaker is usually somebody from the family or someone you hire. So it's either that or go into a nursing home, which is also very expensive. Both options are very expensive because in the accounting that the government does about healthcare, it doesn't take in what the family has to pay, what they have to do. They don't even consider the cost of having one family member no longer work, no longer contribute to the family income. They are cost shifting. In other words, just like other countries who have socialized medicine, they are shifting all of the responsibility on the family. I mean, there should be some, but families aren't nurses. Not everybody in a family is a nurse. They're shifting all of the work to them to take care of somebody and saying, we're not responsible for that. And that means families' incomes are going to go down, not just because they're going to be paying for everybody else's health care and their own, but they're not going to be working. And that's huge. So productivity is never looked at when you look at the cost to a family. How many times do you have to go back for one illness? I mean, that's part of
so that's the question
cheap
of rationing.
healthcare.
Yeah, if you're only going to, if you're structuring the system so that people get paid only when the individual comes to the hospital and the bandage gets changed or the surgery gets done, and then after that, the people are on their own. The patients are on their own. And so what the research is beginning to show is that those people go home and develop other complications, other infections, other issues, and they're back in the hospital within a week for some predictable, preventable extrapolation from the original event. And so what hospitals have begun to do is experiment with sending nursing care to the home to follow up for 2 or 3 days, weeks, whatever is required, to help these people transition. And they're finding that there are then fewer rehospitalization occurrences, which means the total dollar cost of treating that patient has gone down.
No, that's actually smart, and that's not rationing.
And
that's not rationing. That's just a smarter way to deliver health care.
But as part of the conversation that we have to have, how do we take these finite resources and spread them among people who need them for the best benefit, the maximum benefit, the most efficient benefit? And one of the things that you get very passionate about is the whole conversation about antibiotics and the assignment of medicines in a sequence. You know, you can't take this medicine unless you've tried this one, or you have to start here.
Yeah, you have to start with the cheapest drug. But
and who says that? Is that the pharmacy, the insurance company, the medical protocol, the federal government?
Interestingly enough, it's basically the medical community bowing to
outside pressure
from insurance companies and the government, because they're saying, well, we won't pay for that, or you have to pre-certify it. Anytime you have to pre-certify something, it means you have to have a person in your office on the phone all day trying to pre-certify a drug that costs like $30.
Which is a salary that you're having to pay.
Which is what I'm having to pay somebody in my office.
And record keeping you're having to do.
Right. So doctors go, forget it. I'm not doing that. Just take the drug.
Yeah.
And that's a problem. I mean, that's a problem because that drug's not going to work and you're going to be back. So they're giving you a drug that's 50% effective first.
Right. So
not always.
Half the time it'll work.
Half the time it'll work, and then there's a percentage there where you're just going to be sick and you're not going to go back because you don't have time to go back.
Right.
And you don't feel like going in for nothing again. And so, but if you do go back, then you have to have another prescription, another copay to the doctor, and another copay to your pharmacy. Get the second drug that most probably will take care of it. And then you only have to go to a third drug usually when it's a terrible infection, and you should probably be hospitalized for that. But we're talking about infections and antibiotics, and instead of thinking about the person in front of us as doctors, we're thinking, oh, what a hassle, and I'm going to have to be on the phone, and I'm going to have to, we shouldn't have to think about that. I shouldn't have to sit there and think, this drug is the drug they need, but I don't want to go through the hassle.
It's going to cost me an hour of my time.
Yeah, and somebody else's time,
Right.
and a hassle, and multiple phone calls, which means multiple people in my office have to be hired to take those calls.
Well, and talking to whom?
And talking to insurance
you make
companies.
a phone call to an insurance company.
I'm talking to
that's
somebody
hired
with a high
an
school
untrained
education.
hourly wage,
Which
who's
is not-
looking at a computer printout that says no.
Right, that's all they say, no. No matter who they're talking to. And then if it gets really bad, if it's surgery, then you have to talk to the medical director.
Yeah.
And I had lots of talks with the medical director who were not in my specialty, telling me I couldn't do a hysterectomy.
Right.
They didn't know anything about why you do hysterectomies. They're an internist. They've never done one in their lives, and they don't talk to the women that need them.
Right.
So they would tell me I didn't need to do them, and I would tell them I was doing it anyway, and that I'd have to call the newspaper if they wouldn't let me do it, and then they'd always let me do it. I mean, I had to
But
threaten
how
them
much
with
time
exposure.
and stress
It was terrible
for
stress
advocacy
for
do
doctors.
you have to spend? Yeah.
I mean, if you're really doing your job as a physician, you should be spending your time with your patient, right? Instead of on the phone with an insurance company.
Yeah.
So yes, the insurance companies are a big problem, and they take a huge amount of money out of the system, and that money could be spent on you. But, I mean, their profits are outrageous, and you should just go look them up. Look up United Healthcare and what they pay their medical director, and I mean, it's in the millions and millions. So that's where your money's going, and it's going to people who are mid-level, non-medical people to tell
Whose job is to
doctors
say no. Yeah.
I
Because
mean,
their job is to hold as much money in their account as they can.
right.
It's not to spend it to make you better.
So that's another kind of rationing. That's not governmental rationing.
Right.
That's the insurance company rationing.
That's the marketplace.
Because you're paying them to take care of you, and then they don't take care of you. That's a problem. And it's not that they can make your rates go up. They don't have to prove anything to make your rates go up next year. They don't have to prove you spent money. They can just say, oh, we need more profit. And here's the next thing in terms of profit. They don't look at the profit or the amount of money saved over anything but 1 quarter, 3 months. So it's an immediate savings. So if they save money in this 3 months, or they pay out less than they did the last 3 months, then their profits go up and their stock goes up, and they make more money, they make more bonuses. It doesn't come back to you. But that 3 months isn't what tells doctors whether you're healthy. It's the next year or 2 years or 3 years.
Yeah.
If we spend money on sending somebody to stop smoking, on psychological kind of care, and then hypnotism or something like that to get them to stop smoking, that's saving that person's healthcare dollar over a long period of time.
Right.
That's not saving in the first 3 months, because you're going to spend money to save money.
I remember one time I was working with a woman that was significantly depressed, and she had an insurance company that was very resistant to authorizing sessions. And I had to, they would only give me 3 or 4, and then I'd have to reapply, and that was pretty atypical. And I would get rejected, have to write a treatment plan, have to speak to a committee in an appeal. And
That's
so,
really what your doctor's doing when
so I
they're
was spending
not seeing
time
you.
doing all that, and one of the people on the other end of the phone in one of these conversations says to me, "Do you not understand that this woman has a lifetime cap in her coverage, and she's 50 years old, and we're concerned that she'll reach her lifetime cap?" And I said, not only do I not understand, I don't care.
Right.
My issue
needs it
isn't
now.
what she's going to need in 25 years. My issue is what does she need right now. And right now, she fits all the criteria that I've been trained to identify. She is in need. This is critical. She is suicidal. And if she kills herself, then she isn't going to use her cap.
That's right.
So authorize the treatment. And they did. But
this is the problem with the current system. The current system is run by insurance companies, but the government didn't get rid of the insurance companies. They just added another level of problem.
yeah.
They didn't get rid of that profit margin. They didn't get rid of what the insurance companies do. They didn't get rid of anything. They just added another level of cost and bureaucracy to medical care. So what's happening is not only do we have one enemy to healthcare where it's personalized healthcare, we have now another enemy who is trying to give everybody the lowest level of care. So if you have something that you need that's above that, you won't get it. And eventually, hospitals won't buy MRIs because they're higher level of care and they're expensive. Or they won't buy new equipment, or they won't pay for nurses on the floor because it's not paid for, because everybody, there's going to be a flood of people in the system, I guess. That's what they say. I'm not sure that that's true, but they say that because, honestly, I think everybody's covered by Medicare, Medicaid, or private insurance. There's only a small number of people who have nothing. So I'm not positive that that's really the truth, but they're going to lower the level of care. We're going to be like every other country that has to fight for the minimum to keep us alive. And honestly, I'm scared to think about what's going to happen in 10 years because we are going to be rationed, and it's not a closed system. If we had...
Okay, so what do you mean by a closed system?
Okay. A closed system in terms of economics is one person's paying. Okay, so we're
single payer.
A single payer, which is the government in most socialized systems. So they're paying for the doctors, the hospitals, the medicines, the wheelchairs, the scooters, all of the medical equipment that you need. One payer here, and then the taxpayers are paying that one payer.
Right.
And then there's nobody else in the system. So that's closed. That means the person that's dividing the money up and the people that are voting them in and receiving the service are closed. Everything kind of goes around like this. There's no outside forces. So in a closed system, if I save money on one patient, then I can use more money on another patient. What that means is delay in treatment. If I have a really sick patient that I've had to spend money on, then it's my job to ration health care and give less care to somebody else or delay their care.
Well, unless, and here may be a difference, if it's the government and it's a closed system, then the money stays in the government's pocket to be used in the system. If it's a private corporate system, you get what's called a capitation contract. If I sign a contract with General Motors to see their employees in the St. Louis area, they'll give me a contract for $20,000 for this year. And then I have to see however many I see, but I don't get more than 20,000.
Right.
So the fewer I see, the less I see, the more money I make for myself out of that 20,000. So that's a closed system as well.
But not really, because the insurance company is making profit out of it. There's a profit factor.
Well, that's the profit factor. That's what.
There's a profit factor.
So that's the distinction.
And then you have to also deal with the pharmaceutical companies making the profit, and I mean, there's
so
other
multiple systems, so it's not closed. Okay.
Right. So there's multiple systems on top of each other,
Yeah.
and everybody makes a profit. So that's more money taken out of the system.
Okay.
So there's still rationing in that. I think that if you see more people, you get so many dollars per person you see, person you take care of.
All right.
So you see more people, so shorter visits, less care.
Right.
More money for you.
Faster turnstile.
That's not really
in and
good
out.
motivation for a doctor either.
No.
I mean, it should be, I get to spend time with my patient, and I get to take that time to treat them so that they don't have to come back every month. You know, it shouldn't be that
Yes.
I'm trying to see them the shortest period of time
Or
and
I'm only
make them come
treating your
back every
knee
month.
today, come back next week for your ears.
Right.
Yeah.
Right. And that is the way the system's kind of set up now,
moving.
which is opposite what we're taught. Mm-hmm. We're not taught that. Maybe they're taught that now. I don't know that. But
Well,
we're
when you
not
say what we're
taught.
taught, you're talking about what physicians are taught in medical school is that a patient presents themselves and you spend time with them finding out what is wrong with this person, what's causing this, and what treatments can I provide that will remedy this so that they're healthy.
And if they need another kind of treatment, then I send them to a different type of doctor or
Right.
specialist. So figuring out what they need and then referring to another specialist.
Okay, so individual patients come into your office that you see, that's one way of looking at medical questions in this country. But sometimes there are larger groups or larger issues that sweep through the country. And so concepts like triage have to be discussed.
Yeah.
There are discussions, when you talk about managing medical cost in an effective way, do you have in a county like St. Louis County with 2 million people, do you have 20 hospitals, and does each hospital have a cancer center and a heart center and a liver center? Or do you have 20 hospitals and one of them has a cancer center and one of them has a heart center? I mean, what's the best way to make those decisions?
But you can't do that. The government does control that. The government comes in and decides whether you can have a cancer center because there's one down the street.
Okay.
Okay, so a hospital can't just say, I want to put in a cancer center.
So they have to apply to the government
and say, how many beds do we have? How many beds, how many people need these services? How many services are here? Are we duplicating services? If we are, we don't get to do that.
Okay.
So you have to apply to, and I don't know the agency, I should, but it's been a long time ago before when I testified in the Missouri State Legislature to bring a women's center
Yes.
to an independent women's hospital. We lost.
Starts
but
with a J. It's J something.
JCCA. I don't know what it means. Anyway, it's
Yeah.
JCCA.
Yeah.
And they come in and they qualify hospitals, but they also figure out need. How many beds are left open? How many beds are used? Do you need more? Do you need another wing on your hospital or
But
not?
it makes sense that those questions have to be asked and
No,
answered.
I understand that. And that's
a kind of rationing.
But that keeps the hospital from wasting money.
Right.
But it's still a hospital. They still have to figure out their own dollars and cents. They're not going to spend money on something they don't think they can make money on.
Well,
It's still a capitalist system in terms of that.
Yes. Yes, it is. What I'm getting is we were having a conversation before we started about your experience with the National Guard, and the
Right.
word you were using wasn't triage. It was monage.
Oh no, it was moulage.
Moulage.
Okay, so let me straighten this out. Rationing that we were talking about is rationing that occurs for just overall medical care, surgeries, non-emergent medical care. Okay, that's rationing by how much money we have and how many people we have in the system, and how many layers have to be paid for
Right.
within the system. So.
And
when
it's either happening by the government or by the insurance companies.
Or right now, both in the
Okay.
in the new care system, it's with both of them.
Okay.
So we're adding cost.
All right.
That's the rationing I was talking about. Now there's triage. When you come into the emergency room and say there's a huge trauma on the highway and there's 50 people to come in.
Right.
In the ER, they have a triage system. The sickest people
Right.
go in first, and they are seen by doctors, and they are triaged to surgery, or they're triaged to IVs, or they're triaged to pre-surgery. They're sent to the places that patient needs the most, okay? So the sicker people get treated first, and the people who are less sick last. But in the military, you are out on the field, you don't have a hospital, and you don't have very many doctors. It's just 2 or 3 doctors usually in a military trauma center. So you have some nurses, you have some PAs, but you get a huge number of people who are wounded, okay? And it's a different triage system. And I was horrified, actually, when I worked with the National Guard, but this is what they have to do. So this makes sense. We were to go through, and people were dressed up like they were carried in. It was like a pretend trauma. And St. Louis goes through this like once a year
Yeah, I
at a
think most
different
regions do, yeah.
area, and then the National Guard and hospitals all participate. Well, then they have people who volunteer, and they're all dressed up in certain kind of blood and goo and stuff, and they come in, and they're told what to say. Okay, so I played the part of the doctor one time, and then I played a part of a pregnant patient because I'm an OB, and I had just given a lecture about what you do and what you don't do in a bleeding pregnant patient, and of course the first doctor killed me. I mean, not really, but I mean, because he did exactly opposite of what I said you should do. So that's how they learn. But bottom line is, triage is, in that circumstance, is quite different. If you're really hurt, you get a black thing put on your gurney. That means we're putting you over to the side, and we're not dealing with you because you're going to die. That's it. I'm not kidding you. Then there's sick and we can fix them, which is red, and I believe these were the colors. And then green, which is you're just minorly hurt, you're waiting.
Yeah.
So they go to the reds and take care of them. They have nurses kind of make everybody hang out until
And
they're
if green
better.
escalates,
And
or
if
red
they
escalates,
change, I went from a red when I was the pregnant person that was bleeding, and then they did a vag exam, which you're not supposed to do without an ultrasound. Then I went to black.
Right.
Because I wasn't going to make it to the hospital. I was going to die anyway, so they just put me over in the black.
Yeah, which was two deaths.
Which is 2 deaths.
Yeah.
But that is military triage.
Yeah.
And that is rationing.
Yeah.
Rationing, however you want to pronounce it.
Sure.
But that's what they have to do in the field.
So part of what makes the conversation...
But we aren't in the field.
Well,
we're not in the field.
no.
That kind of rationing doesn't apply to us.
No, it doesn't. But that's part of what makes this conversation so complex, is we use the same word to cover multiple concepts. And so when we talk about rationing, there are legitimate questions that have to be asked and answered. There are power centers or decision matrix centers that have to function. But as a consumer and as a taxpayer, you want to be involved in that conversation. So educate yourself, talk to the people that you need to talk to, whether that is your physician, your pharmacist, or your congressman. But get involved in helping solve this problem, because you will be impacted by it.
Email your questions or comments to podcast@biobalancehealth.com. You can find the BioBalance Healthcast on iTunes and on YouTube. For more information about bioidentical hormone pellet therapy and other reverse aging solutions, visit biobalancehealth.com or call 314-993-0963. You can find Dr. Maupin on Twitter @Dr. Kathy Maupin and on Facebook at facebook.com/biobalancehealth. Find Brett Newcomb at brettnewcomb.com.